I'm honored to present you to Pascal Borry. He's a professor from Leuven in Belgium. He's going to give us a talk on expanded carrier screening and ethical challenges. We're very happy to have you here, and I'm specifically interested to hear how could we as clinicians handling this new tool. Thank you very much for coming.
Okay, thank you very much, and thank you for the invitation. I have no slide, but I have no conflicts to disclose. But maybe before I start, I can say, well, it was very interesting for me to stay here this 2 days. I'm mainly used to another setting of conferences. I'm working in a department of public health, working on ethical issues, and mainly working at attending conferences of geneticists. I was member of the board of the European Society of Human Genetics, and I refer as well to some documents we made in that context. So maybe before I start and just trying to give a little bit an overview of my presentation, I will first try to say something about the concept of carrier screening and make it distinguish it from carrier testing. I will show some of the companies that are at this moment providing carrier offers and well, it's even broader services that are currently being offered to show the disparity that exists today at the level of carrier screening. And for me, this is not only a technical matter. I think it's a fundamental ethical problem at this moment with regard to the offer that is being given. And then I will continue with describing, I think, some of the challenges that are linked to offering carrier screening. Not that I say I'm not against offering carrier screening, not at all. I think it's an important development, but I'm sure at the level of implementation, there are some challenges ahead in order to make sure that it's being offered in the most optimal way. I think it's important as well to realize that some of the things that I say are really can use in different contexts, in the sense that I will often refer to an offer of carrier screening to the general public. And I can realize, and I will refer sometimes to the context of assisted reproduction, but maybe the specificities of one context might not be completely the same in the other context. So I think it's important to realize in a dialogue to what extent these contexts are different or similar. So first of all, I think carrier testing is of course not something new. It exists already for a long time, and we know that in families where you have an index patient with a certain condition, that relatives of that index patients are at risk, should be informed about the fact that they could be carrier, and that carrier testing can be done in that context for reproductive decision making. I mean, it's very commonly known as the cascade screening. This is already being done for a long time, in fact. When we talk about carrier screening, I'm really focusing here about the offer of the detection of carrier status in persons and preferably in couples, in fact, who do not have a priori increased risk of having a child with a certain condition. And I think that's really important to realize. This is quite a different context. So what are the advantages of carrier screening? I think they are quite obvious. Having more knowledge about carrier status in couples, that can increase reproductive decision making. You all can make informed choices. As a consequence, it could lead to a reduction of certain disease incidence for certain conditions. But it could as well be used to enable better knowledge at the level of when children are born, at the level of perinatal diagnosis and treatment, which could diminish disease severities. And to give one example of one of the companies at this moment, there are some companies offering or integrating phenylketonuria in certain offers, which is a fact in most of the countries, a condition that is being screened at birth through neonatal screening. So, and this brings, of course, as well a quite interesting debate at the level of what is the relationship between carrier screening and neonatal screening. So, what is the potential to benefit prospective parents? Of course, increased information about genetic risks, strengthening of reproductive autonomy and informed decision making, and that's what I'd like to emphasize. If you are doing and offering carrier screening in a context outside pregnancy, which would be preconceptional, or in the context of an artificial reproduction before parents or future parents are want to have a pregnancy. It has, of course, less time constraints than when you would offer such a test during pregnancy. This means less pressure, less emotional stress compared to screening during pregnancy. So what are different options? I don't think I need to discuss all the different options that are offered to parents. So when did the story of carrier screening in fact start? And carrier screening is already a long time present, but has never been fully implemented. I think the first discussion of moving on from one condition being offered through carrier screening, I mean, there have been pilot programs for cystic fibrosis, for example. There have been pilot programs for hemoglobinopathies, so one conditions being offered to certain groups. And that has already been done in the 1990s, in fact. But what we have seen is that since 2010, more or less, and I think as a consequence of that paper, there was a kind of a proof of concept of offering carrier screening for many more conditions at the same time. And the concept was a universal carrier test that included many conditions in one single test. This was further developed by a study in Bell, here where he described saying like, well, for more than 7,000 disorders that have Mendelian inheritance, more than 1,400 are recessive. And in his study, he provided a kind of a proof of concept for one test that included a targeted analysis of more than 400 genes for representing 448 severe recessive childhood onset conditions. And in that study, it was as well clear that, of course, we are all carriers of different conditions. The average carrier burden for those conditions would be 2.8 and within a range of 0 to 7. So what is and that becomes a kind of an ethical point as well. It's like, what is the big difference? Is that, first of all, the concept is a universal carrier screening. And in fact, we are moving away from an ethnicity-based panel. And that's an important point in the sense that there have been some studies that have been made on ethnicity-oriented panels that focused on the fact that ethnicity-oriented panels could have a stigmatizing effect on certain communities, for example. And so one of the advantages of moving away from ethnicity-based screening panels is that you are moving away as well from a stigmatizing effect. So various companies have started to offer that, and I could show many more slides of offers that are currently available. And I will continue with this offer in a moment as well and comment on that. Of course, carrier screening is not only relevant for couples in the general population that are not necessarily looking for assisted reproduction, but it's clear that it's as well relevant in the context of assisted reproduction. If you look at the study of Platinga, and this is based in Groningen, where at this moment they are offering a test for a panel of 50 conditions, they anticipate there that the prevalence of at-risk couples would be approximately 1%. Another study, referred here from Martin et al., referred that approximately in the assisted reproduction context that the risk would be higher. Here they assume 5%, which might be. This is a bit strange, maybe, because why would there be a higher risk? This might be due to the fact that that in this specific test, more conditions are being tested, because it's here a panel of, and that's the reason I added, of more than 500 diseases, and maybe a small set of couples, only 139 couples undergoing assisted reproduction. So I think that's definitely an area of discussion, like what is exactly now the amount of couples that could benefit from this and could be identified as a carrier couple. But for sure, I think it would be somewhere between 1% and 3%. So there is not that much known at this moment about expanded carrier screening in an assisted reproductive context. There is one study here that makes a retrospective analysis of a test that was offered to more than 50,000 couples. I think that's the only study available at this moment. In that context, there's a test for approximately 100 conditions was offered, and there more than 537 at-risk couples were identified, so approximately 1%. A survey was sent to these couples trying to ask what the reason was that they were undergoing this test, and we see that although it's a very small response rate, that approximately half was doing the test within the context of what was called a fertility workup. So I would interpret that as in the context of assisted reproduction. And that other contexts, other reasons that were referred were routine screening, multiple miscarriages, ethnicity, and consanguinity. And of course, consanguinity might not be the best reason to do expanded carrier screening, because it's likely that this very unique maybe variants might not just be part of that panel, and that's as well something which is important to realize. So if we look at current offers, we did last year a study that was published in Prenatal Diagnosis trying to analyze the current offers of expanded carrier screening. And from an ethical perspective and societal perspective, for me, this is somewhat disturbing, in the sense that you see a very huge variety in the current offers. A company screening for approximately 41 conditions on the one extreme, and a company screening for more than 1,700 conditions on the other side. And you can see here the numbers of conditions screened as well as the number of genes screened. Moreover, while you would hope that at least there is a set of conditions that everyone would screen, or that at least that there is an agreement on, well, even that was not the case. There was only one condition that was offered by all providers, which is cystic fibrosis. And even if you look further, at the level of, at least for the providers that we knew what kind of mutations that was analyzed, well, we see as well that at the mutation level there was a huge variety between the mutations analyzed. So I think from that perspective, looking at, there is a huge variety at the level of severity of the conditions integrated. There is as well a huge variety at the level of the age of onset. There are childhood onset conditions being integrated, but as well conditions that develop later in life. There is a huge difference at the expression of certain conditions, and as well a huge difference at the level of the penetrance of certain conditions. So what is striking is that there is a kind of a lack of coherent criteria, and we as well observe that some conditions are being offered that for which in fact there exist clinical recommendations saying like, well, you should not offer carrier screening for that conditions, and there are some examples of that. So for me the question is like, is more always better? And of course I realize, and having talked as well to several of these providers, of course they just try to find a kind of an competitive advantage towards each other. And having spoken to some companies, they have often said to me like, well, we try to do the best offer available, and then we try to offer something more that another company is not offering. But coming from a public health perspective and thinking about what is an optimal care, I think we should do a better job in that context. I think we should try to search what good criteria are in order to develop a panel, and make sure that you develop a professional standards about what should be integrated. And I realize, of course, that this is a very difficult job, but I'm not sure if the situation how it is today is preferable. I think as well what is important is that if you develop and discuss about these things, is that you integrate a stakeholder perspective. What I have seen at this moment, that the current offers that are available are mainly expert-based. There have been no discussions with people outside, I would say, really the field of experts. And I think these are issues that are really have public societal impact and should be discussed as well in a larger context. We did a study with European geneticists. We are doing at this moment another study with patient organizations on this. This has not been done or published at this moment. So, I will very shortly summarize what we found and when talking with geneticists on this. So we asked them, in fact, and we asked other things as well, but we asked first of all about how they would see the ideal panel for expanded carrier screening. We asked as well questions about implementation and offer and how to organize that, to organize the counseling and so on, but I will not describe this in this presentation. And what we see, we find a huge agreement at the level of the first two elements here. So disorders resulting in childhood mortality, severe childhood disability, chronic health problems requiring continuous treatment, are very much in agreement. As well, disorders whose natural course can accurately be predicted on the genotype. This is an important criterion. There should be a good correlation between the genotype and the phenotype. If you don't know, if you cannot use a genotype to predict a phenotype, it becomes very difficult for interpretation and very difficult to start using it. Very strong agreement with the people we interviewed was at the level of disorders that are considered to be mild and where the genotype is a poor predictor of the clinical phenotype. And there was no agreement in two areas: disorders that develop in adulthood and disorders inherited in an X-linked fashion. And that was often linked to a technical aspect and the fact that for some X-linked conditions there could be some health effects as well. Of course, criteria are one thing. Implementing criteria and trying to see what these criteria mean might be another thing. And we realize that as well. There have been some guidelines that have been developed at this moment. There is a guideline of the American College of Medical Genetics. There is one of the European Society of Human Genetics. And there is as well an American document that regroups different organizations, such as the American College of Obstetricians and Gynecologists, National Society of Genetic Counselors, and so on. So if you look at the agreements, I mean, the criteria on which there is agreement, well, severity, severe enough that would warrant prenatal diagnosis of termination of pregnancy. I mean, you can see here how this is being formulated in the different, by the different organizations. At the level of the age of onset, there is a clear preference here for childhood onset disorders. As you can see, it may be preferable to exclude conditions in which the disorder is associated most often with an adult onset phenotype. And as in the interviews, a clear preference for pathogenic mutations with a high penetrance and a low variable expressivity. So clearly pathogenic. This means that if you develop a test, well, there is really a focus about specificity being more important than sensitivity. You need to be able to interpret what you find. There should be a good correlation. Of course, when we discuss about all these kind of conditions, and if you take a more societal point of view, I think the obvious question that will come for society is like, well, is this eugenics? What are we doing on this? And this is a kind of a basic question. It's not, I don't think this is a new question. I mean, if we discuss about, and I was involved as Guido as well, in a report on non-invasive prenatal diagnosis for trisomy 21, 18, and 13. And of course, there as well, we have debates about, well, offering a prenatal screening test. Is this not eugenics? And so on. So I think it's very obvious when we would start to offer this kind of test to society, as professionals, we need to have an answer whether or not or how we stand vis-à-vis that issue. And of course, this touches with the fundamental issues when we discuss about reproductive decision-making, reproductive screening in general. It's the tension between what is the goal, in fact, of offering a prenatal test. Are we doing this to increase reproductive decision-making? Or are we doing that to prevent the birth of a child with a certain disorder? And what is the first goal, the primary goal? I think this is a fundamental tension that you will always have. And I think as professionals, I think we need to be very much aware that the aim, finally, of offering such a test, well, can never be prevention. Prevention can be the consequence of offering a test. But fundamentally, you offer a test in order to make people aware of the different options that exist, in order to make them aware that they can make a choice, an informed choice based on that. And the consequence of that, of course, could be that the incidence of a birth with a certain condition could decrease. But that's a very fundamental concept, and it is not always that easy. Because when offering a certain test, you can, of course, create certain expectations. And that's the reason I added here, well, you can create certain social pressures, because it can become the norm to do a certain test. And there could be anticipatory regret from parents, future parents, because they would feel like, I need to do this test because otherwise I will have regrets. And people sometimes might give comments to people like, oh, why didn't you take this test? You should have done this. I don't think there is a way out of this. This is a tension that will constantly exist. And this is a kind of a test that we need to balance and inform very well about. But we need to realize that the tension is fundamentally there. And this means that in guiding individuals, couples, when offering this test, that we should realize that, and being very good at the level of the pre-test counseling and the post-test counseling, and as well being non-directive in these offers. And that's another study that we did. We looked at, well, what kind of information materials are available at this moment by the different providers. And yeah, we think that there, at that level, well, definitely the quality of the information could be improved at that level. So why do I show that? I abuse the situation to refer to 2 books that I have written with a colleague, which was in a project together with illustrators and cartoonists. But I think this raises to another point as well, and it is a point where I would like and love to give you a lot of evidence, but I don't think we have a lot of evidence. It's like, well, we don't really know what the social impact on the individual and on society is of offering certain tests. So I wouldn't assume that there would be a case, and I think we need to educate people that, of course, that we all are carriers, and that there are no reasons to start discriminating individuals, stigmatizing individuals or couples. But of course, you don't really know what really the impact is on individuals. We know there are some studies that have been performed when offering carrier screening for one single condition. We have seen that very often there is, when knowing and getting information about being an impact, that there is, at least for a short period of time, a period of shock and a period of adaptation on that knowledge, that usually this is not staying very long. We see that there might be a perception on the impact on their own health. Some studies have shown that people certainly start to think that being a carrier can have an impact on their own health. Of course, these were all studies for a long time ago. No study exists at this moment on expanded carrier screening. So I think more evidence there is necessary, but it shows as well the need for good information and a good general understanding in society. What is definitely, I think, an important risk when offering carrier screening is the idea that people might get that this is a kind of a reassurance that this will be for sure a test for a healthy child. And of course, that's not the case. There are many other conditions that are not being inherited in a recessive pattern. There are other reasons where children could get risks for conditions. There are de novo mutations as well. And of course, all the panels are being focused on specific mutations, and there are many mutations that could lead to the condition, but that are maybe not integrated in a certain test. So there is always a residual risk, and you might calculate that residual risk as well, if we have enough evidence. But of course, that's an important element that is absolutely essential when communicating about carrier screening tests. And of course, stigmatization and discrimination, well, there has been some knowledge on that when offering the test in certain ethnic groups, specifically in the Doria Shorim, for example, in the Jewish context. We have shown that the knowledge of or identification of carrier status has led to some stigmatization there. Is there a reason to assume that would might happen in other contexts? Likely not, but I think this is an element that needs attention as well. So, and with the end, I would like to refer to two documents we have been working on. One is this document from the European Society of Human Genetics that provides some recommendation when starting to offer an expanded carrier screening test. And this is a document from the Health Council in Belgium. We have been working on a document in order to organize the implementation of a carrier screening test. This was not really focused on an assisted reproduction context, but more in the general public. At this moment, we are working with genetic centers to develop a carrier screening offer and organize the implementation of an offer in a carrier screening for a carrier screening test. We are lucky to have been funded for a project in order to study the social impact of offering this test and analyzing as well the motivations of individuals to take up this test. And if there is anyone interested to know more about that or interested to collaborate on this, I would definitely welcome any email on this. And here are my email contacts. And with this, I would like to close my presentation. Thank you.
Thank you very much for this clear presentation, which makes the responsibility for those who actually give the advices to the patients a heavy burden. Is there any questions? Otherwise, yeah. Rita?
Is really more a comment and about stigmatization of being a carrier, for instance. I think that is very much based on education of the end user. So we have quite an extensive experience with the expanded carrier screening in the group, because we've been proposing expanded carrier screening in the context of oocyte donation to the donors and the recipient, well, the husband of the recipient. And at the beginning, there were quite a little bit of perplexity and people asking if they could get a donor that was clean. But that went away when you explained that everyone is a carrier for something, and being a carrier does not equate to having a negative trait, and is in fact what drives differences among us. And the patients were the same, but the way they saw it changed with education. So I think this will be a very fluid situation in the next decade or so. But I would not despair, really. I think if you explain it clearly, people would understand.
Yeah, I fundamentally agree. I think, and what we see is many of the studies that have referred to certain problems are all from a context, I would say, where, 15, 20 years ago, and for one condition. So I would indeed hope that, well, we have evolved already somewhat at the level of education, general level in the society, and at least as well at the level of the professionals. I think there has already been a big involvement at that side. And I think the knowledge of carrier status as well is probably already a little bit more known in other contexts as well, thinking about the context of newborn screening, where as well carrier status for cystic fibrosis in the context where newborn screening for that condition is being offered is as well regularly discovered. So I agree with you on that.
Andreas?
Yes. Also just maybe more a comment than a question. I'm here.
Sorry, I was looking.
I think there's also, or there might be also, some sort of legal or malpractice aspect to it, because I remember an article in the lay press maybe 2-3 months ago. A clinic in the UK got obviously sued because an IVF couple gave birth to a child with cystic fibrosis, and they claimed that they have not been advised or counseled about the possibility to do a carrier screening, to have preconceptional options for their decision-making process, and that obviously is a big topic. If you do first visits, if you do counseling, and you miss, I mean, you don't have, maybe your clinic doesn't offer it, but you miss to inform, that might end up in a legal malpractice chaos.
Yeah. That's indeed an important issue, although I'm wondering, I still feel this is in the early phases of development, and you see that there are different practices around the world. I mean, some countries where there is already more integration or not. I mean, I think that what you would need, I would say, in order to say that this is malpractice is not following a certain guideline that exists in your country that says that you should offer this. So I'm not sure if that really would hold into court, but of course I'm not a lawyer, I'm not seeing how this would work in that context. But I don't think it's a good practice to start offering because you are afraid of getting a lawsuit because of not doing it. So I hope there are better professional reasons to start doing it than that.